Okay, good afternoon, everybody. We'll just take a few seconds whilst people slowly enter in and connect from the virtual lobby in the waiting room. We have well over 100 people registered us out today. So this is really great that we've got a good participation, good registration for this event today. And slowly we see now. We can see on the side of the panelists, the numbers trickling in. And I've filibustering a little bit just to make sure as many people get to see the start as possible. But you don't see that, of course, as an attendee as people are arriving. So just continue to speak one more second whilst we allow the maximum number of people in. And now I think we're a good moment to start. So thank you, everybody, for being available here this afternoon for the latest in the series of webinars we've been doing now for over 3 years on the European Code Against Cancer. These webinars started as a way to disseminate and communicate about the specific messages of the European Code Against Cancer. But today we're going to look more in detail at a broader topic, and that's the topic of measuring the awareness of the European Code Against Cancer in the population. And this is important because Europe's Beating Cancer Plan has a lot of commitments about the European Code Against Cancer and includes some ambitious targets for the dissemination, the awareness, knowledge of the European Code itself. That's what we're going to dive into here today for this webinar. My name is David Ritchie. I'm the Cancer Prevention Manager at ECL. ECL's a network of 30 cancer societies in the European region who work to promote current primary, secondary prevention, all of the evidence that's communicated by the European Code Against Cancer, amongst other things. And the European Code Against Cancer is really a central element of our work. And we're delighted to have worked on this for many years, also in close collaboration with a number of the speakers today, not least the International Agency for Research on Cancer, which are the coordinators of the 4th and the forthcoming 5th edition of the European Code. Next slide, please. So you can see just some brief housekeeping. As you know, this is a webinar, so we try to make use of the specific functions that are available there. Mostly we will be channeling through the Q&A function, all of your questions and comments that you wish to raise today. There is a chat function which you can use to interact, but we're asking that you use the Q&A function for any specific questions you have towards the panelists, which we'll raise at points in the agenda. Of course, as it's a webinar, it's not an open mic session, so there's no facility to take the floor from the audience in terms of speaking using the microphone, but that's why we encourage you strongly to use the Q&A function. There will be a possibility also to give feedback and evaluation survey at the end, and also if we have time, we've planned for a short poll to be used at the end of the webinar. We'll ask you some questions about the topics we've been discussing here today. And then lastly, this webinar, like all the other webinars that we've done over the last 3 years, is recorded and will be made available on the playlist on YouTube that ECL curates, which has all of these webinars. And that will be available shortly after the conclusion of today's webinar. Next slide, please. So to the agenda today. As I mentioned at the outset, our discussion today is really looking at the ambitious targets and goals within the Europe's Beating Cancer Plan for measuring the awareness of the European Code Against Cancer. We spoke a lot about promoting it different ways in the past. You can use the code to inform people about actions they can take to reduce their cancer risk. But we want to talk very specifically here today about the methods that could be deployed to actually measure if the messages of the Code Against Cancer are penetrating through and are being taken up by the public at large, who ultimately are the end user. The goal that we want to reach is to improve their knowledge and to change their behavior consistent with the messages of the code. And to guide us through this interesting topic today, we have 5 great speakers. Firstly, we have Silvia Rubanova from DG Santé. Silvia is a policy officer in the Cancer Task Force, and she will give us an intro and snapshot of the relevant things in Europe's Beating Cancer Plan to the implementation of, but also the measurement and possibilities there may be for the awareness of the European Code Against Cancer. And then following Sylvia will be Dr. Joachim Schutz, who's the head of the Environment Lifestyle Epidemiology branch at IARC in Lyon, which is a part of the WHO UN family. Joachim was the PI of the 4th edition of the European Code Against Cancer, and will also likewise have a similar role for the next version. After Joachim, we will have Meritxell from ECL, Meritxell Morafe La Rosa. She's a research assistant who's worked with us for a number of years. And Mary will look specifically at our first attempt a couple of years ago at ECL to evaluate and measure the awareness of the code as an entity, but also some of the messages in the wider population. Then following Mary will be Dr. João Foucault, who's from the Institute Cancer in France, who will look at the specific example of the French Cancer Barometer. So this is really a tool that looks at the awareness and uptake of cancer prevention messages at the national level. And then finally, we have Dr. Carolina Espina, also from IARC, who was the scientific coordinator of the 4th edition and likewise for the 5th edition, who will give us some insights on the plans and ideas going towards the future when we'll have the 5th edition of the European Code Against Cancer. So without any further ado, this is the agenda. These are our great speakers. And now I can invite Sylvia to take the floor to give us the intro to the relevant parts of Europe's Beating Cancer Plan that has impact on the European Code Against Cancer. Thank you, Sylvia.
Thank you very much and good afternoon to everyone. Thank you for inviting me to this meeting to present the Europe's Beating Cancer Plan and its actions that are linked to the European Code Against Cancer. As it was already said, I am part of the Cancer Task Force, which was set up under the Public Health Directorate of the European Commission, and we are based in Luxembourg. So first, a little bit of background to the cancer plan. The aim of the Europe's Beating Cancer Plan is to tackle the entire disease pathway, and it is structured around the 4 key action areas, being it prevention, early detection, diagnosis and treatment, and quality of life of cancer patients and survivors. The cancer plan also includes a focus on research and innovation, and also on the use of digitalization and new technologies. It also it does not involve only the health sector, but it requires it does not involve only the health sector, but it requires efforts also from many other sectors, and of course it also needs engagement from various stakeholders. The plan also aims to reduce inequalities by sharing experience and resources across the EU, or by supporting regions and cities that may have less capacity than the others. There is also the fact that cancer is an important cause of death by disease in very little children, and that there are different types of cancer in children compared to adults, and also the spread of the cancer and the treatment differs. So this led us to include actions on childhood cancer in the cancer plan as well. The plan is structured around 10 flagship initiatives and a number of actions that are supporting the 4 areas that I have just mentioned. Of course, all the parts of the cancer plan are equally important, but prevention is where we can make a big difference through simple everyday changes in our behaviors. The fact that 40% of cancer cases are preventable or can be attributed to preventable causes is giving us a huge scope of action under the cancer plan. The prevention does not only save lives, but it is also the most cost-effective strategy. And there is no doubt that the prevention is always more effective and better than any cure. With the cancer plan, we aim to raise awareness and address key risk factors, such as, for example, cancers that are caused by smoking, harmful alcohol consumption, diets, obesity, and lack of physical activity. And we also encourage citizens to shift their behavior through measures such as taxations or promoting healthier choices. Our starting point on prevention is, however, having access to information on cancer risks and on the information what can cause cancer. And with the cancer plan, we are aiming to make at least 80% of the population aware of the European Code Against Cancer by 2025. An important element of the cancer plan was the implementation roadmap, which we published last year in November. And the aim of this roadmap is to monitor the developments on the actions that are included in the action plan. The roadmap outlines how the Commission intends to achieve the different targets, and it takes the various actions that are proposed in the cancer plan and breaks them down into concrete objectives that are to be achieved until 2025. It also provides indicators to see whether the actions are implemented successfully. The implementation of the action plan has already started and it's bearing its fruit. And for example, in September last year, the Commission launched the Healthy Lifestyle for All initiative, which I will tell you about later. We have 3 groups which are regularly meeting and which are there to ensure a smooth governance of the cancer plan. One is the subgroup on cancer, which was set up under the steering group on health promotion and disease prevention. And it follows jointly the implementation of the cancer plan and the cancer mission, which is focusing on research and engages member states experts from both sides, from the health and the research side. It also serves as a forum to us and to the member states to exchange the information on the implementation of the cancer plan at national and at the EU level. Then secondly, we have the Commission internal cancer implementation group, which brings together the various Commission services which are working on cancer, and we have regular meetings to ensure internal coherence of policy actions and funding. And the third one is the stakeholder contact group. And the idea here is to bring together the stakeholders that can discuss and engage. We have for this EU health policy platform, which is an online platform. And last year we launched a call for expression of interest for thematic groups where interested stakeholders were invited or could have registered. The idea is to engage the stakeholders around the 6 thematic groups which are matching the different pillars of the cancer plan. Oops. Yes. The implementation of the cancer plan is ensured through various funding instruments, and the total budget of this instrument is 4 billion euros. A substantial share of the budget comes, of course, from the EU Health Programme, but there are also other EU funding instruments, for example, the Horizon Europe or the Digital Europe Programme, which are also funding actions against cancer. Last year, under the EU Health Programme, we launched 12 action grants and 4 joint actions, and I will tell you a bit more in the next slide about them. And the work program for 2022 has been recently adopted, and it includes again a number of actions which are focusing mainly on prevention and diagnosis. And just a couple of days ago, the HADEA, the European Health and Digital Executive Agency, which is in charge of the health program, published the first round of calls for proposals under this year's work plan. So now coming to the concrete actions. One of the actions that is foreseen to be funded under the EU for Health program is the update of the European Code Against Cancer. The updated 5th edition will take into account the latest scientific developments, should add new evidence-based recommendations on reducing the risks, and we are planning here a grant to the IARC to support them in carrying out this work. Another action that plans to boost cancer prevention is to support the dissemination of the cancer code by developing an EU mobile app for cancer prevention. And the aim here is to reach to the general population to spread the knowledge about the cancer code and to provide concrete information to people how they can reduce their cancer risks. And it should also help people to understand the recommendations of the cancer code and help them to translate these recommendations into messages or changes that they can apply in their everyday lives. There are two elements which are linked to this app. One is, of course, to develop the IT tool itself, the software that will be behind this app, and we are planning a tender for that. And secondly, there was a call for proposal which was published last year and which focused on actions that covered promotion and training activities for general population on the recommendations of the cancer code that will be disseminated via this app. And then the second element of this proposal was supporting activities that develop and share best practices which strengthen health literacy in cancer prevention and care programs by, for example, preparing easy to understand materials. Another important initiative that I have already mentioned was launched in September, and it was the Healthy Lifestyle for All initiative. And the aim of this initiative is to promote sport, physical activity, and healthy diets in the EU, which is also one of the messages in the European Code Against Cancer, how people can reduce the risk of cancer, that they should eat healthy, should include physical activities in everyday life, and limit the time they spend sitting. So there was a call for proposal under the EU for Health program, which was published last year, also linked to this initiative, and the funding aims to support activities that are involving member states, regional or local governments, educational establishments, and various civil society organizations. And the action is aimed to support increase of regular physical activity, promote healthy lifestyles, and exchange best practices on health literacy. So this was just a short summary of the cancer plan and the implementation. And if you have any questions, please ask them in the chat. Thank you very much.
Fantastic. Thank you very much, Sylvia, for that great overview. We'll have time later on, of course, to come back and pick your brains on certain things. Of course, as Sylvia said, use the chat, but also specific questions for the Q&A function. So thank you very much for that, Sylvia. And now I hand over to Joachim, who I think will share his screen with the presentation. Joachim will give us a really important and interesting fundamental presentation, because of course we're talking now about cancer prevention, but we must really understand that we're on the same basis here. We know exactly that we're on the same level of understanding what we're referring to. So he will give us a great introductory presentation, because sometimes this data, the information can be a bit hard to penetrate, or can be a little bit misunderstood or ambiguous to interpretation. So it's really a pleasure and a privilege to have Joachim now for our presentation. So over to you, Joachim.
Okay, thank you very much, David, for your very kind introduction. And this is indeed a little bit of a methodological talk, but we thought it's very useful before we go into the European Code Against Cancer, so that we are all on the same page when looking at these epidemiological, statistical, empirical figures that you always see when you talk about cancer prevention. And for this, I'm going to one slide that more or less tries to summarize all we know about cancer, primary cancer prevention in Europe here. And first is how many people are affected. This is what you see on the left side of the slide. So in Europe, and here I'm talking about the continental Europe, so the 40 countries as to the United Nations definition, not the EU. We have annually a bit more than 4 million new cases of cancer every year. And this number will actually rise, the annual number of cases will rise in the next 20-25 years to more than 5 million cases per year. 5.2 million is projected for the year 2040. So if you look at the complete time period, this means 100 million new cases of cancer in Europe over the next 20-25 years. And as I said, this is a projection. So this is what most likely will happen. This is not some kind of worst case scenario. And this shows that even the most affluent countries cannot just put all their efforts in treatment of cancer, but we really need to enforce primary prevention to reduce this number. And the good news is that we have tools like the European Code Against Cancer, where we have laid out which are the public health recommendations, how you can reduce your risk of cancer. And the pie chart here on the right side of this slide shows you what we know about successful primary cancer prevention. So all the the pie shows all the 100% of cancer cases, and that the messages that we see from this is that for 50% of cancers, we have not yet identified the underlying cause. So that means also that for etiological research for cancer, there's still a lot to do because many causes of cancer have not been identified. So for 50% of cancers, roughly, we know the causes. There's a kind of small percentage where we know the causes, but they are not modifiable. So that's, for instance, genetics or naturally occurring chemicals or radiations that we can reduce the exposure, but not eliminate the exposure, or something like reproductive factors. But for more than 40%, we would be able to prevent cancer. So that would be 40 out of the 100 million. And what you see with these different colors, that tobacco makes up 20%, so half of all the preventable cancers, with other very substantial contributions from obesity, physical inactivity, unhealthy diets, and alcohol consumption, and to a little lesser extent also infections, radiations, and the different chemicals in the occupational setting or the environment. So a bit more than 40% of cancer we estimate we can prevent. So how do we achieve this knowledge? And for this, you have to understand how we come from the understanding of the causes of cancer to prevention. And this is more or less in 3 individual steps. So the first one is the identification of a hazard. So whether substance is carcinogenic or not. And this comes usually from a mix of different studies. So we have the experimental studies here on cell lines, also on experimental animals. We have the epidemiology, and ideally this comes up with some kind of yes, no question whether something is carcinogenic or not. Unfortunately, for many substances, we are somewhere in between. So these are probable, possible carcinogens where we clearly need more research. But from whether something is carcinogenic, we still don't know the value for prevention. And this is because the individual risk of the different factors is also very different. And for most of actually cancer risk factors, we know there's a certain exposure outcome relationship, usually in the way that with increasing exposure, also your cancer risk increases. So we have to understand this dose-response relationship to really know what the individual risk of cancer is. So for instance, for a very heavy smoker, we know they have 20 times the lung cancer risk of a non-smoker. And if you want to see what is the population risk, so how many people are affected on a population level, then we have to multiply this number with how many people are exposed in the population. So we can end up more or less with the same number for a cancer factor that is a very high individual risk, but only few people are exposed in the population, as compared to a cancer risk factor that is a very low individual risk, but substantial parts of the population are exposed. So if you take one example, here we take the artificial ultraviolet radiation from sunbed use. So we have identified in many studies that this is really carcinogenic. So it's an identified, established cancer risk factor. If we put the epidemiological studies together to look at the dose-response relationship, then we see there's a 1.8% increase in skin melanoma risk with each session of sunbed use per year. So that would mean, for instance, if somebody is having a session of sunbed use every week, so that is 52 times per year, you would double your risk of skin melanoma. And if we apply this individual risk to the population of France, which has been done here in the last step, then we can estimate that 382 cases of melanoma would be preventable in France with a ban of use of sunbeds. So this is where these figures come from. And the basic epidemiological figures for understanding the burden of cancer, this is the cancer incidence. So we can first describe the cancer burden, of course, and the frequency of the events, which is just the incident number of cancer cases or death from cases in a given year, or more importantly, the incidence rate. So for COVID-19, We all know now what an incidence rate is, but this is usually the 7-day incidence that is given. So for cancer, we measure the incidence usually per year and by a population of 100,000. And then we have to very importantly distinct between the crude incidence rate and the age standardized incidence rate. And the reason for the age standardization is that because age is a major risk factor for cancer, we know that each cancer type has its very distinct age distribution. So if we want to see whether the cancer risk changes in the population, we have to factor in the changes in the age distribution of the underlying population, because otherwise our trends in the cancer risk would be overlaid by the trends in the aging of the population. But of course, when we do capacity planning, then we need a crude incidence rate, because how many hospitals we need, how much we need for treatment. Here, of course, we need the absolute number of cases because we have to plan our capacities accordingly. So the mortality rate, this is defined like the incidence rate just based on cancer death. So how do we do this age standardization? And the age standardizations, we pretend that the entire world would have the same age distribution, and then we look how the cancer distribution would look like for this general age distribution. So this is the world standard population that you see here on the left side, which is defined by WHO. And of course, this more or less follows roughly how the age distribution looks on a global scale. And then you see that it's really a pyramid. The proportions are getting smaller with increasing age. Now, if you look at Europe, then you see that our pyramids here in Europe usually look a little bit different. And this is France as an example. So it rather has a little bit of a belly here than being a true pyramid. But this means that with the age standardization, if we apply this to France, we give less weight to the older age groups. And these are the age groups where usually the cancer occurs. And we give more weight actually to the younger age groups with world standard population, where cancer is, of course, not so common. And the resulting effect is, when you look then at the numbers, so the crude incidence rate for Europe is 569 per 100,000 per year. And if you look at the age standardized incidence rate, it's 282. So you see there's a big difference, but both convey the independent messages. But what must not happen is that mixing the two up depending on which context you are talking about. And this is what I like to demonstrate by looking at the time trends of lung cancer incidence here with the data of the Nordic countries. So on the left side, you see the age standardized incidence rate, which more or less displays the lung cancer risk over time. So time comparisons are usually made with the age standardized rate so that the underlying age distribution does not play any role. And then you see that because of the decrease, and we know that tobacco is, of course, the driving risk factor for lung cancer. And then you see that there's an increase from 1960 to the 80s, but then with the decrease of smoking in men, you also actually see a decrease in the risk of lung cancer. For women, the shape of the curve, unfortunately, looks a little bit different. You see more or less a constant increase from the 1960s over the following 50 to 60 years. However, if you look at the absolute numbers, and this is based on the crude incidence rate here, then you see because of the increase in the life expectancy in Europe over the past decades, that we have proportionally more elderly now in the population. So we have a higher at-risk group, and this means that the absolute number of lung cancer cases is in fact going up. So you see, even in the men where normally there would be a decrease in the lung cancer risk, we see an increase in the absolute numbers because the at-risk group is getting larger. And in the women, we really see a very steep increase, a 14 to 15-fold increase in numbers over the past 50 to 60 years. So these two should not be mixed up. So when I sometimes hear in the news that people talk about a tobacco epidemic, like this is something that happened in the past, or I read sentences like, oh, is sitting the new smoking? Then we really have to be aware. The peak of the tobacco-related cancer epidemic is not in the 80s, 70s, or 80s, where the Marlboro man was on TV every day and when everybody was allowed to smoke in the office. The most tobacco-related cancer cases is actually what we have just now in the 2020s. So despite all the effect in prevention, because of the increase in the at-risk population, the numbers are still going up. The other effect that is important to know for the primary prevention is the long duration that we have between the initial exposure and then the occurrence of the cancer, which can be decades. And this is an example here from Germany for a cancer called mesothelioma. It's a pleural cancer. And the main risk factor for this cancer is asbestos. And asbestos has been banned in Europe in the early 1990s. But what you see actually, that we still have an increase in the mesothelioma death even up to the 2020. So 30 years after the ban, numbers are still going up. And only then comes the reversal of the trend. But you see, even in 2030, we would have the same number as in 2000. And it would be 50 to 60 years later that the banning effect really shows in the primary prevention cancer rates. So mesothelioma is a very extreme example because we know the latency is so long for this cancer. But for most of the cancer risk factors, we are talking about decades. So we have to be aware that if we do measures in prevention today, it will take some time until you see them really in a resulting lowering of the incidence rates. So this brings me already to the conclusions. So what you should keep in mind is that of Europe's cancer burden today, we know about causes of cancer for 50% and more to 40% would be preventable. And with tobacco actually still being responsible for half of these preventable cancers. The European Code Against Cancer is strictly based on the scientific evidence from understanding to prevention and gives you the recommendations of how to achieve these 40% of reduction. And it's important to be aware of the figures that we use in cancer prevention. Do not mix up crude incidence rates and age standardized incidence rates. These are the ones used for capacity planning. And when you want to see really the burden and absolute numbers in the population, the age standardized incidence rates are used for comparisons on geography or time trends. And then, of course, the population attributable fractions, they can tell you about the risk factor composition in your population. And by this, thanks a lot for your attention.
That's excellent. And thank you so much, Joachim, for that great and very to time presentation there that really concluded with the key points about the population attributable fractions, which are critical for the development of the code against cancer, but selecting the right messages that we ultimately want to see measured in terms of awareness of the population and then people acting on them consistent over time. So sure there will be questions for you in the batch of Q&As that will follow just after the next presentation, for which I'm delighted to hand over to my colleague Merichel, who will make a presentation about the efforts that we did at ECL together with IARC and also with our members, the Cancer Leagues, to do a modest evaluation of the impact of the European Code Against Cancer. So this is a kind of first effort that can go into the actions towards measuring the ambitious awareness targets of Europe's Beating Cancer Plan for what concerns the code. So Mary, thanks for being available and over to you.
Thank you. Just checking, can you see my screen?
Yep.
Perfect, wonderful. Then good afternoon, everyone. As I did introduce, I'm Maritei, as a research associate for ECL. And today I'll be presenting a brief introduction to our efforts into assessing the impact of the European Code Against Cancer. Apologies, I'm having some issues passing the screen. Okay, there you go. So just briefly, as a declaration of interest, ECL has received funds from the EU third health program, and we also have an unrestricted grant from L'Oréal Garnier for education purposes. And as David initially presented, ECL is a membership organization. We currently have 30 national cancer societies throughout Europe as under our umbrella organization. So this is a paper that came out of our initial efforts to understand the impact that the European Code has had over the past 30 years in the context of cancer prevention throughout Europe. As Dr. Schutz was presenting, the European Code Against Cancer is a highly evidence-based tool that has been available for public health practitioners throughout Europe, But to our surprise, ever since its first publication in 1987, there had been little to no evaluation of its impact throughout Europe. So what is the European Code Against Cancer? As it's been presented, it's a tool that contains 12 easy to understand messages directed at the general population that indicate on how to, what would lead to behavior change in order to reduce cancer risk, because as it's been showcased by Dr. Schutz, up to 40 to 50% of cancer could be prevented if such recommendations were to be uptaken. So in terms of the methods that we use to assess the impact of the code, we used a mixed methods approach. We first conducted a survey throughout 8 countries throughout Europe, covering both North, South, Central, Eastern countries in Europe. That was a survey that was directed at the general population. We used an omnibus technique, and the questions throughout the survey were trying to understand the awareness that the general population had about the code, and also whether learning about its content would sort of lead to behavior change. Then additionally to that, we also conducted 28 key informant interviews within 25 different countries with the European Code Against Cancer promoters or main promoters. And those were typically cancer prevention officers throughout the cancer societies that we work with directly through ECL. So now I'm gonna dive into the results of our survey. First, I'll talk a little bit about the survey results, so that is directed at the general population, and then we will dive a little bit more onto the results from the interviews with key informants. So as for the survey, the awareness throughout Europe of the code itself as an entity is quite dispersed and quite low, we could say. It ranges from 2% within the UK up to 21% in Hungary and Poland. And interestingly, once respondents had read the European Code Against Cancer, they were quite likely to say or to report that they would make changes or lifestyle changes within the reading of the code. It went up to 88% in Portugal. Interestingly, such results were different by gender, in which women were more likely to report that they had learned something new after reading the code and that they would make changes in lifestyle after reading such. The age effect was not so clear or was not so determined unless for questions 4 and 5, in which older cohorts were less likely to report that they had learned something new from reading the code or that they would make lifestyle changes. Finally, then going into the interviews results. We conducted 28 key informant interviews as before mentioned. And the first question that we had was whether promoters were actually promoting the code as an entity, as a unit, or rather whether they were focusing on separate messages of the code. Interestingly, within Central and Eastern Europe, most of the respondents, that was 6 out of 7, did promote the code as an entity. Those were also the countries where we saw a bigger awareness of the code as a brand, while in Northern Europe, none of them did so. Then we delved a bit more into intrinsic and extrinsic factors that were sort of facilitators and barriers towards the code promotion. Interestingly, as inherent factors, that is directly related to the code, most of respondents cited the fact that it's evidence-based as a very facilitator factor to maintain. And then as for external factors, the interest from different stakeholders, they play quite an interesting role. So for instance, while most respondents did report that promoters, that is public health professionals throughout Europe had a positive impact on the code's promotion, they did sense that healthcare professionals were not so much aware of the code and were a bit of a barrier towards its promotion. Finally, also most of respondents did report that competing lifestyle factors messages coming from other disease prevention efforts were also a barrier towards its promotion. Apologies, the slides Great. All right, great. So as we've seen throughout the results of the study, the awareness of the code itself varies quite a lot throughout Europe. But interestingly, it's being used a lot by healthcare, by public health promoters as an evidence-based tool into which to construct public health programs on top of that. And additionally, also as a base for advocacy on their efforts to promote healthy lifestyle throughout Europe. And notably, it is to be mentioned that awareness does not equal impact. And therefore, the evaluation of the code impact has to undergo further research efforts in that sense. In conclusion, we've showcased today the results from an effort to understand both at a functional and structural level the impact of the code throughout Europe. And those are important results when we're thinking, how do we go ahead to measure progress in achieving the Europe's Beating Cancer Plan health literacy goal. That is the so-called 80% awareness of the code throughout Europe. And we want to be thinking on perhaps the fact that throughout the target population, so that is the general population, we want to be assessing the awareness on different health style related messages, while throughout promoters, maybe then we want to be assessing their awareness on the code as an entity and as a tool. And finally, as colleagues from IARC have mentioned, the 5th edition of the code is upcoming, and therefore we do call for a systematic evaluation delving further into the impact of the code throughout Europe so that it can better guide its next edition and it can better boost its effectivity and its impact. Finally, I would like to acknowledge the authors of these efforts to assess the impact of the code. And that's it from my side. Thank you.
Excellent. Thank you very much, Mary. This is a great summary overview of the work we did there. So thank you very much for that. We planned for a short Q&A now, but I think we can take them all at the end in order to make back some of the time, if that's okay with the previous speakers. So thanks once again, Mary. And now we move ahead to the second half of the agenda. We had our first efforts there from Mary to do a modest evaluation of awareness and attitudes towards the code from the perspective of ECL in a number of different countries. But now we're going to zoom into one particular country, and a very good country, as it's the current presidency holder of the EU in France. And I'm delighted to hand over now to Jérôme Foucault, who's the head of Department for Prevention Research at the Institut National de Cancer of France, who will show us the specific example of the French Cancer Barometer. Thank you, Joachim. Thank you, Jérôme.
Thank you, David. Thank you again for your invitation. I'm very, very glad to be here today to share some results about this very interesting study of the perception of the cancer risk factor in France, named the Barometer Cancer. I prepared this conference with my two colleagues, Anne Flarguima and Iris Samanka. I would like to thank my two colleagues for their support for this conference. Well, maybe before to start the conference, a few words about the French National Cancer Institute. It's a governmental organization. It's a scientific and health agency in charge of the new cancer strategy in France. And we have a very, very, very large action plan for this new decade strategy. On the next slide, please, and thank you very much for your support. What is the context of barometer cancer? The barometer cancer is a national survey among the French population conducted each 5 years. And the aim of this study is to analyze the perception of nutrition, tobacco, alcohol, screening practices, cancer risk factor, care and information about cancer. And one of the main interests of this study is to be able to have the opportunity to evaluate, to analyze the evolution of the perception on the same items. This study is one of the actions of the last cancer control plan. Well, in the next slide, thank you. It's indeed necessary to have an idea about the perception of the cancer risk factor. Indeed, you know that for the cancer risk factor, you have endogenous factors like age, genetic, sex, and it's sometimes complicated to have an impact of this cancer. But we have cancer risk factor, but for the other one, exogenous factors like environmental or personal lifestyle factor, as radiation, population, viral infection, and lifestyle, we can have an impact. And one of the main determinant of this behavior to protect the population and also the environment, it's the perception of the cancer risk factor. And in the end, it is the objective of this study, as you can see on the next slide. It is the aim of this study, investigate the perception of the French population and also analyze the evolution. Well, I suggest to move forward on the method. Have a look at the time. What about the method? First of all, the population, we recruit a population among 15 years old to 70 years old, living in France and speaking fluently in French. For that, a list of eligible phone number was generated using a random digital dialing. And to be included the participant, indeed the participant have to have a landline or a mobile phone line. It is necessary. And after that, we use a KISS method to be able to have a final list. When we have this final list, we use the specific procedure. We send an information letter before to call to the people in the list. And we try to obtain verbal consent to be involved in the study. And after that, we start the interview. Well, what about the method again? What about the survey? On the next slide, please. On this survey, we have around 130 items. It's possible indeed to compare the items in between the different period. And the questionnaire starts with a socio-demographic question about sex, age, something very classical. And after that, we have specific items about perception of being at risk of cancer, and list of items about the cancer risk factor, behavioral, environmental, and also psychological factors. The item was created based on the analysis of scientific literature. And for the statistical analysis, something very classical to compare the differences, we use kidder test and also odd ratios adjusted for age and sex. Well, I suggest to move forward now for the results. What about the results? We can see that we have three populations. The sample were representative of the French population. If you consider age, sex, monthly income, educational level, occupational, and region of residence. In 2005, we are around 3,500 people. It's something very close in 2010 and a little bit more maybe in 2015. And you can see the rate of people below the figure. Well, the first results, indeed, it is not possible to present all the results today, and I've chosen to introduce and to discuss with you just some results. Maybe the first one, very interesting first one, it's about the perception of the risk to have a cancer during their lifetime. And we can see that 71% of the French population perceived to be at risk to be affected by a cancer during the lifetime. This perception is more perceived among the people over 24 years old. Indeed, for young people, talk about cancer, something maybe complicated because it's difficult for them to have this perception. For the smoker, we can see maybe that we have a good impact of the communication. Those with an occupational status, living couple, and with a high level of education. And in the scientific literature, we showed this result before, and in France, we have the same situation. In the next slide, please, we will discuss about the main cancer risk factor. Tobacco is responsible for around 20% of the avoidable cancer in France. And if we ask to the people, do you think that smoking is cancer risk factor, we can see that 97-98% of the French population thinks that smoking can provoke a cancer. It is more passive among the population with the diploma or the baccalaureate, or the people with higher income. But it's extremely interesting to note that we have no link with the smoking status. We have another point here, and please go back on the slide. Something very interesting to note on that. Indeed, we have around 98% of the French population thinks that tobacco is a cancer risk factor, but you have these results once you gather the answer that you are sure that it's a cancer risk factor, or you think that it's probably a cancer risk factor. If you have a look at only the people who are sure, we are around more 75% of the French population. Sorry. What about alcohol? The next one. Thank you very much. In this slide, we have to consider two populations, men and women, because at this period, we have a distinction between men and women concerning the consumption of alcohol. And the level at this period was 3 glasses for men and 2 glasses for women. And we can see that around 85% of the men of the French population think that drink 3 glasses of alcohol can provoke a cancer. It's a cancer risk factor, and it's around 78% for the women. We can see very interesting differences between men and women. Well, here again, we can see that we have some differences among the population due to the low impact, or also the level of education, and also the impact of the users. We can see that we have different profile between the people who have a regular consumption of alcohol to compare to the other one. On the other one, it's one of the main cancer risk factors. The third one, it's indeed the overweight and obesity. Then we test these items to compare to the other years, and we can see that it's around 75% of the French population perceives that overweight or obesity can increase the cancer risk factor. In here again, we have some differences due to the low income level of education. Well, I think that to have the care to the time, yes, I have to move forward. Well, what about the evolution? Very quickly, we can see that, for example, smoking tobacco, sun exposure, eating food treated with chemical product, or also the impact of the air pollution, we can see that the results are really stable if you compare 2005 to 2050. We can see some differences between different other cancer risk factors, for example, the lack of activity, or also, for example, the drinking, but we discussed about that before. It is not possible to discuss all these results, but I will just show you the 3 main cancer risk factor with a very strong evolution. The first one, it's in 2015, we can see that 76% of the French population thinks that live next to a cell phone relay antenna can provoke a cancer. It is a cancer risk factor, and we can see a very, very strong evolution of this perception, around 25% since 2005. It's indeed, we can maybe explain this result by the fact that in 2005 we didn't have a lot of relay antenna, and we do not have a very important communication on that. And I think that this fact can explain these results. Another one very interesting is the impact of stress. Indeed, we do not have a lot of evidence on the impact of the stress on cancer. It is not really to date a cancer risk factor, but for the French population, it is not nothing. We have something around that 80% of the French population thinks that suffering the stress of the modern life can be a cancer risk factor. And indeed, we have also a very interesting result about the impact of eating foodstuff treated with chemical product, with an increase of 9.3 between since 2005. And indeed, we can definitely explain this result by the very, very important communication around the organic food by the industry. Well, to conclude, I would like just to discuss with you about the perspective of this study. We start last year's the 4th edition of the Barometer Cancer. Indeed, due to the situation of the COVID-19, it wasn't possible to conduct it in 2020. And the study was start in 2021, and we finished the study, and we are now in the phase of the analysis of the results, and we hope to be able to publish the results at the end of the year. And also, we have started a new program of cancer, of barometer cancer, and we start a project with National Control Cancer from Irish people, and indeed it's possible to find some results and some detail of this presentation on the link. And I would like to thank you again. I would like to thank you especially, Richie, David, for the invitation.
Excellent. Thank you so much, Jérôme. This is a great presentation and overview of the French experience and the practical example of the Cancer Barometer, and some really interesting results there, which I'm sure we'll speak on in the following discussion session. So thanks very much for keeping to the time also. And now to the final presentation, I hand over to our long-term collaborator from IARC, Carolina Espina, who, as I mentioned at the outset, is the coordinator of the 4th edition, working with the Wacom in the environment and epidemiology branch. And Carolina will talk us through now the steps towards the future, which is the forthcoming 5th edition. So Carolina, over to you.
Thank you, David. I hope you can see my slides on presentation mode.
Yep.
Yep, thank you.
Great.
So I'm going to present a bit of an overview of the last activities done in the context of the European Code Against Cancer. So as you know, we launched the 4th edition in 2014. Sorry, and the recommendations have been evolving. So you can see here the number of total recommendations in the different editions. Sorry. In the last edition, we also added a new layer of information, which was this website with more than 200 Q&A, questions and answers for the general public, and the 14 peer review publications referring to each of the recommendations, the methodology, the project in general. So we are building up with new editions, not only on the recommendations, but in different outputs related to the code. So this is what I'm going to call the planning and development phase of the ECAC 4 that happened already. And as I mentioned in my previous slide, this had 3 levels of information. The code itself with the 12 recommendations for this 4th edition, the comprehensive website, and the peer review publications. This is in scientific language. So now, after the launch, we move into the dissemination, implementation, and evaluation phase of the ECAC 4. And here we have several outputs coming out of this. The study that Mary has just presented to you on the evaluation of the impact of the code. We also had as a review on the impact of the code on cancer policies and cancer national plans in different countries in Europe. That is very informative. And also, we perform a work in the context of the IPAC, the last EU joint action on cancer, where we published a report and a publication on the recommendations or the roadmap for sustainability and maintenance of future codes. So what needed to be in place for future codes. And this I'm going to explain in detail later. But we also embark in some implementation and dissemination research studies. And this year I'm showing an app of a mobile phone, and this fits very nicely to one of the actions that Sylvia mentioned before, and the grant that is now to be decided on this new app for helping boosting the dissemination of the European code. So this is a study, a small study that we have done in Spain. We actually finished the field work last week, so we are about to start the analysis. And we did it here in the south of Spain because it's the Ministry of Health has a platform. It's a multi-channel existing platform that the health department delivers different sort of messages and information on health in general and on specific topics to the whole population in that region. So it's more than 80 million people. And this app is downloaded currently by more than 2 million people. So we thought it was a perfect setting to do an implementation and dissemination research study where you want to deliver an intervention in the real world conditions. So we have done an intervention with periodic messages through an app and through SMS as well, because not everyone has an app. Is a randomized controlled single blind trial. And we are looking at feasibility of this intervention in the future in terms of recruitment rate, acceptability by the public of receiving this type of messages, satisfaction, and even patterns of cell phone use. We are also involved in other activities, which is the evaluation of an online learning program that I'm going to explain in the next slide for health advocates. And now we are testing it in oncology nurses and other health professionals. And finally, we are starting also a collaboration with a pan-European promotion campaign of the European Code for different healthcare professionals. So this is one of the main activities that we have done in dissemination in the last years. And together with ECL, we did first a needs assessment survey among the cancer leagues of the need to understand really the science behind the recommendations and also the methodology, because we thought it was very important to understand why some recommendations were there, some others were not there. So this is crucial. So we launched in April last year 12 modules on each of the recommendations and one on the methodology. This is online already in our platform. It's in a IARC learning platform, but also the Cancer Prevention Europe platform. And recently, in November, last November, we launched the second set of these models, which is again 12 models on each of the recommendations. But now we give information on the latest evidence, myths, and controversies, because we know there has been some time already since the code was launched. So science is moving forward. We have new data, but we are not giving recommendations because this will be part of the 5th edition of the code. So this is just to show you an example. On tobacco, we are addressing new evidence on vaping products, for example. We have a lot of EU experts involved in these learning models. We have also new evidence on alcohol. And in air pollution, which was not a recommendation in the previous code, for example. So we want to address all those things where we have new data. And of course, we wanted to reach the cancer leagues and the cancer leagues at the local level. So really that the people will learn what is behind. And so we are doing an effort together with ECL and several national cancer leagues to translate it in different languages. So we have already French almost finished, and Hungarian. We are working hard to have Spanish and Polish soon. And we know that we will have German, probably Dutch and Italian in the future. So I will keep you updated. This is a very good resource to learn about cancer prevention in general and more about the code. So this slide summarizes the roadmap that I was talking about before. These are the 8 recommendations that we came up with in a broad consultation across Europe with experts, scientists, also disseminators, etc. And I want to point this out because we are supposed to implement these recommendations in the new code. I mean, this is a way of moving forward with new codes. We don't want to repeat the same type of thing. So we are also improving our methodology. So the first recommendation, which is very important, is not only addressing 2 individual measures in the code, but also population level measures. So there's a policy component here that we will have to add in the 5th edition of the code. Of course, as in the recommendation number 2, we need a process with a mapping, a prioritization plan, and also an evaluation of the impact. So this will be included in the next 5th edition. So the evaluation, we will start thinking of the evaluation of the impact from the start in order to have it in place. And of course, we need a governance structure with multiple stakeholders. Another important point in recommendation number 3 was how to align our messages with those common to other NCDs. So we'll have experts already dealing with other NCDs, prevention messages. Recommendation number 5 addresses different target groups. So again, the general public is the main target group, but now we want to reach health professionals and also policymakers. But by including this policy dimension in the code, we are already addressing also policymakers. And of course, a dissemination plan where we also explore how to reach better to the public, which are the best channels, what improvements we need to do in the communication. So this will add to the improvement in health literacy in general in cancer prevention. And now I want to bring you to an initiative that we have just launched in IARC a few weeks ago, which is the World Code Against Cancer Framework. And this is the website that was launched. As you can see here, we already have embedded the previous European Code Against Cancer. We will replace it here, of course, with a new edition. And we have already space for the first regional code that we are doing outside of Europe, which is the one in Latin America and the Caribbean. And this framework, what tries to do is to standardize the methodology, adapted, of course, for the specificities of a given region. We are also in conversations with Asia, for example, with a network of cancer institutes. So we want to have it aligned and also to develop the outputs, as I told you before, level 1, level 2, level 3, in the most appropriate way for each region of the world. So now I come to last year, where the Europe's Beating Cancer Plan announced the next 5th edition, and they give us this very challenging goal of raising awareness of the code up to 80% of the European population. And you have just heard from Mary that we have a lot of work to do to reach this goal. And we have here a progress indicator on the percentage of population being aware of at least half of the code. So I think here is where we have to work towards. So as mentioned before by Silvia, the kickoff of this new 5th edition will start this year in a couple of months. So again, we will have a planning and development phase of the ECAC 5 in the next 2 years. And we plan to launch it on the World Cancer Date in 2025. But what happened after? Again, we will have a dissemination, implementation, and evaluation phase of the code. And here is what would happen after the launch. We need a sustainability and monitoring process to measure progress in awareness, and if we attain the goal that the Europe's Beating Cancer Plan is putting us as a milestone. So just wanted to give a bit of hints of what we are doing. Because we are now doing the Latin American code, we are already advancing on the methodology. We are improving, we are enhancing this methodology. So in the European code, we clearly have this roadmap that will guide us, but we are already developing some tools, and we are gaining experience with the Latin American project. For example, we are preparing, or we have prepared already a methodological guideline that we will adapt to the Europe situation. We have some checklists, we have some different tools that help experts to navigate through the whole process, which is quite long. If you may remember, or if you did the methodology course that I mentioned before, you have learned about these 5 criteria that guide the development of the European code. And here in pink, you can see new additions that we have added to the previous criteria, which is, well, again, the scientific evidence has to be solid. This is the first, and this does not change. But in the relevancy for the region, we are including not only the epidemiological patterns, but also in social inequalities that may exist, availability and affordability of interventions that we want to recommend, etc. And here also in the number 4, you can see that we are adding also other target groups, and this is where we are adding the policy dimension that we are already including in the Latin American Code. And finally, in clear communication, we'll not only stop at the messages, but also investigated innovative dissemination strategies and channels. And this aligns again perfectly with the call on the app, the EU app. Oh, again, this is the policy dimension that I mentioned before. And what we are planning to do in this phase is a formative implementation research study in the general population. So we would like to have a EU-wide baseline survey. I mean, we have already the data that Mary shows, but again, we should have something continuous in time to see the progress, and specifically now to see what happened with ECAC 5. And we would like also to put together a co-creational study or process, ideally with the cancer leagues and or the youth ambassadors, so more in a qualitative way that would feed into the baseline that we need, the information that the expert needs to receive before working on the recommendations, not to do the same, let's say, mistakes in terms of, look, this recommendation is not reaching the public. It's evidence-based, it's up to date to the science, but it's not reaching the target. And again, we will have to define new outputs. In the previous code, we had a website for the general population. Now, in Latin America and other regional codes, we are addressing health professionals with competency-based microlearning models, for example. This is something that we will have to explore, how to deliver the information in Europe to the different audiences, also to policymakers. So this is all in a planning state. And finally, I wanted to come to the last part on how to measure progress. What would happen after the ECAC 5, and it's something that we will have to start deciding now to build up and to have the tool ready for the future. And here, and as an outcome also of the World Code framework, we want to have knowledge and awareness on the main preventive measures disseminated and impact evaluated. We think this is very important and fits perfectly with the goal of the Europe's Beating Cancer Plan. And for that, we need to measure progress in awareness. So Jerome presented already a national case study. We know that this type of barometers exist in other countries and other tools, but ideally, we will call for a potential standard, sustainable and Europe-wide tool to measure this progression on awareness. For that, we would need a baseline, as I said before. We already have the very good data that Mary presented us, and we need to have an idea of the progress in time of the uptake of the recommendations by the general public. Here, I wanted to show 2 examples of existing tools at the EU level. One is the Eurobarometer. These are public opinion surveys in very different topics, not only health, across Europe, all the member states, of course, and they are done in different frequencies. We have the standard Eurobarometer, which is quite regular, but then we have a special Eurobarometer for specific topics to go a bit more in depth in a particular topic, and flash Eurobarometers, which is ad hoc on a particular topic. And here, for example, we have recently flash Eurobarometer on tobacco products, attitudes and attitudes from the public, I mean, from the European population towards this type of products. We also have on vaccination, particularly very recently on the COVID vaccine. So we think it's a very, it has a lot of potential to create a cancer barometer with a EU-wide scope. So we should build on national experiences and existing tools. There are validated questionnaires on cancer prevention to prepare for such a metrics. I also want to present here from Eurostat the European Health Interview Survey, which is run also periodically in different countries. Here, they have another type of variables. They are already variables on cancer, like frequency of mammography or cervical cancer screening, or even health determinants, weight, physical activity, frequency, about the diet. So it already presents a very good platform if we could introduce some questions about the European code. And it's a platform that could be sustained along the years. So with this, I wanted to conclude. I hope I'm fine as regards the time. And I wanted to show the names of all my collaborators that participated in pieces of this work that I have just presented. Thank you.
Thank you very much, Carolina. This is a great presentation and just on the time. So that's the end of the round of presentations we prepared. Now the floor is open, virtually speaking, for the Q&A. I see already a couple of things I've gone through into the Q&A function, and there's also dynamic interchange on the chat. But to kick things off, we'll go back to the beginning of our presentations. And for Sylvia, a question now. You've had some of the presentations today from Carolina, from Jérôme, and the French experience, Mary, with our study. Can you just give us in a few words some of the insights, some of the thinking already in the Commission about the possible modalities, methods, or means by which it's practical to actually measure awareness of the messages in the public, the messages of the code? You know, Carolina's give her insights and perspectives just there, but it would be great to hear your impressions, if not on a personal basis, perhaps, or if you can speak more openly, it would be very welcome.
Yeah, thank you for the question. Yeah, you saw the different components of the EU health program, and of course this is really an ambitious program. So we have to see, and we have to maybe discuss further how concretely we can measure this awareness. But one thing which I would like to stress here is that not only what is not only important, it's not only the awareness about knowing what are the different messages in the cancer code, but also having an insight maybe on the concrete, how concretely can people take them into account in their everyday lives. So maybe this is also one of the important things that we should focus on, because sitting in front of the TV with an EU app and reading the different advices how people can reduce the risk of cancer, it's probably not very effective. So yeah, maybe this is just the next.
Excellent. Yeah, of course, the long-term goal is to have the behavior change maintained over time. And I think we've had at least the intermediary steps towards that. Measuring awareness quite helpful, and we've had some ideas here. So we're very encouraged by the possibilities in the plan to support that. And then turning to Joachim, thinking about the messages of the code. Of course, in this session, we didn't have a chance to show them one by one, all 12 messages. But one of the important messages, sometimes a bit forgotten, is occupational exposures, because people don't have the same freedoms. They're more limited in their choices and so on towards how they can perhaps have a behavior or practice that reduces their risk of cancer and other potential illnesses. So I was just wondering, from your perspective, if you have anything to say on the gaps, challenges to get good, reliable, comparable data across countries on the exposure, the burden for occupational cancers in Europe. Is this something we need to invest and pay more attention to because of these limitations on choice? You know, it's modifiable, but you lose your job potentially. Let's say if you wanted to work in a less hazardous environment, and of course that's not so easy for many people. So I'd be very interested to hear any thoughts in that direction.
Yeah, David, that's a really good question. And in your question, you already highlight the challenge, because I mean, protection from carcinogens at your workplace is certainly not a responsibility that we can leave to the individual alone. I mean, with the code, we try to help to raise the awareness. I mean, first of all, that these occupational hazards exist, and that people can actually also request from their employer to be informed of what it is, what the different measures that are in place. But I mean, most of the protection measures, they have to be undertaken by the employers. And I mean, providing protection equipment, for instance, I mean, also putting limits on exposure. I mean, sometimes monitoring the exposure of individual, like it is, for example, very common in radiation dosimetry, that you observe the worker's cumulative radiation dose, and if it's start to reach the limit, you would probably even stop having the worker go into specific workplaces. And this also I mean, happens at some workplaces where you inhale the exposures. But nevertheless, there's a lot to do. I mean, I would say in Europe, we are in a pretty comfortable position because, I mean, there's authorities in place that usually have over time really done their best for worker protection. And we can see that for many exposures, there's a decline in exposure trends. So certainly this is something that will also be more important for other parts of the world where there's less worker protection. Nevertheless, we also face challenges in Europe. I mean, with increasing migrant populations that we have in the working sector, I mean, there can be language barriers. There can also be this lack of awareness of what you can actually request. So certainly this needs also a constant adaptation of the situation to make sure that all the protection measures are in place. Because certainly most of the occupational carcinogens are modifiable risk factors. So we do know that with appropriate protection, we can clearly reduce the cancer risk. And at the moment, we estimate about 3 to 5% of cancers in Europe are caused by workplace carcinogens.
That's excellent. Thank you, Joachim. It's really illuminating answer, and I think it's a really important figure to conclude with. This is a big proportion, relatively speaking, so it's a key issue. And then maybe to Jerome, we could pick up on that aspect of your measuring the awareness within the Cancer Barometer in France of occupational cancers. That would be interesting, but we had a lot of interest over many years, but especially in recent months, about the awareness of alcohol as a causal factor, as a major risk factor for cancer. And I noticed in the survey you had quite high awareness in the population from the French public that they knew they could identify that this is a key risk factor. Was that a prompted question or unprompted in terms of how that data was reported? Did they have a choice of a number of measures, or was it presented, this is a risk factor, yes, no, that would be interesting? And then related to that, more methodological question, any perspective you might have as to why we see, for example, in other countries, the awareness of alcohol and its link to cancer being quite low? Is this something you're doing very well in France to inform about this? Thank you.
I am writing your question. Well, indeed, it's very interesting to note that the French population is very aware about the main cancer risk factor. If we are talking about, indeed, alcohol or also tobacco. We have some differences between men and women, as we underline. To answer very clearly to your question, the question is, do you think that tobacco is a cancer risk factor? Absolutely yes, maybe absolutely not. It's something like that. We do not have a specific question on the level in this part of the questionnaire. But when we detail the cancer risk factor, we ask, for example, how many cigarettes do you smoke? Do you think that it's more toxic to smoke a lot of cigarettes or to smoke during a last period? It is possible to have something more precise about the perception about the cancer risk factor. And especially for alcohol, it's also possible to have an idea about the perception of the cancer risk factor. Like, it's possible, for example, to have a comparison of the perception between alcohol and, for example, junk food. Because in the same questionnaire, we ask not a lot of questions, but several questions to be able to have an idea about this perception and how the French people rank the alcohol to compare to the cancer risk factor. It's possible to have that, but we do not have specific question. Do you think that 1 glass is a cancer risk factor, 2 glass? Because it doesn't make sense. For this one, we have to confess that we have changed this question because it doesn't make sense today to ask this question. Do you think that 3 glasses for men and 2 glasses for women is a cancer risk factor? It was a norm few years ago, but we changed that with a recommendation with Santé Publique France, and we have decided to propose another level. I'm sure that it's 10 glasses and not 2 days, and not every day, and to have a break of 2 days. Something very clear for the French population. But we have a lot of communication, and that it's maybe complicated for the French population when you have this very, very long list of the cancer risk factor. It's complicated to think. For the French people, we can guess that they are all on the same level. And for example, if you are exposed to the air pollution or the junk food or this kind of stuff, why I have to avoid to smoke? Yeah, I will have a cancer due to the other, and I can have an impact for the other. And maybe we have probably to deal with that in the cancer, in the code on the next one. Yeah, maybe to be able to rank, for example, for the air pollution, the French people think that the air pollution, it's a very, very important cancer risk factor, but it represents, it's not nothing. I'm not saying that, but it's very, very, the differences is very, very important to compare to tobacco. Is it clear now? Yeah, I spoke a lot. I do apologize for the other.
No, it's perfect. I think you raised some great points that I think I'm also come back to later about the perceptions of the magnitude of risk versus what's in the code, what's not yet in the code or shouldn't be in the code. I think it's really interesting experience that you have there. And I just turned to Mary because you're a medical doctor with license, but also training in public health too. And I just wonder, from your experience as a health professional, what do you think is, what's your opinion from that point of view about the awareness of the code itself, of its messages that are contained within it, within your community that you had at university and so on, not just the peer-to-peer and the fellow students, but in the faculties, and then also your experience briefly with then the national level and the ministries and so on. From point of view of a young medical doctor, do you think the code's well sensibilized, to use borrow a French word, or there's some gaps there?
Yeah, I didn't hear very well the end of the question. I do apologize. Something.
Sorry. Do you want to go, Jerome?
No, please.
Sure. So yeah, there are definitely some gaps from the medical statement, let's say, and not only from the doctor's perspective, but also nursing. And there are so many other healthcare professionals that should be involved in cancer prevention and generally in NCD prevention, right? Personally, I can tell throughout med school, we were never trained much in public health. Definitely did not hear about the European Code Against Cancer. I think we also have to think about which kind of doctors and which kind of healthcare professionals do we target that to, because we think of cancer, right? And we typically think of oncologists. But then when you have a cancer in front of you, sure, you can prevent recurrence, you can prevent secondary cancers, but we should take a step back and sort of have a broader perspective. And probably we should be aiming at general practitioners and primary healthcare providers throughout Europe in terms of cancer prevention and NCD prevention, right? So probably we should also be looking into having further training and further dissemination throughout healthcare training and just having that as a tool, because we do have tools for smoke cessation, for instance. We do have tools for physical activity and the promotion of healthy diets, but we typically do not have tools for a broad one unit entity, sort of NCD prevention that we can easily hand out throughout the practice in a primary healthcare setting. So I would say that's a way to go around it. And that is also something that we did see in the study that we were just presenting before, right? Like there is a lot of awareness of the code itself within the public health practitioners part, but not so much within the healthcare, the ones that are directly facing the patient day to day. And those are the ones that are in front of our target population, the general public, right? And those are the ones that actually have the power. They are big in number, right? And it's just a matter of getting that message to that specific professional body.
Excellent.
I hope that replies your answer.
Yes, always. Thanks, Mary. That's great. And of course, you raised up the interesting points that Carolina also mentioned in terms of the plans that are ongoing at the moment to do studies together with not just medical doctors, but with nurses too. And one question that has come up in the Q&A for Carolina is about the possibility to, in the next edition, also highlight or embed, promote evaluated interventions or programs, practices that can be used but nationally, locally, or in community level to make the messages real, basically to implement in practice the various messages of the code. So it's an additional level in some way to the 3 levels of the current edition of the code. So is that something in the planning, is to include also directly in the next edition, somewhere in the package, examples of population-wide or more target group specific programs which communities, regions, governments, nationally, different levels, or other sort of operators can take and use in practice to make the messages real for people?
Thank you, David. Yes, I think that would fit first in the policy dimension that I meant. I mean, when I say policy, it means any type of population intervention or measures. It can be established policy, or it can be a recommendation on a particular program, etc. There are a lot of tools already out there. There are a lot of international recommendations. There would be probably the need to explore further, to review the literature, to be more specific, and to really recommend what is proven effective and applicable, available for the EU. I mean, the countries we are targeting now. We know there are also, let's say, resources of best practices around Europe. Some interventions are even evaluated. Some others are implemented, and we have we can find that information and see if we can also prepare a particular package. I mean, it would be repackaged things that are already in place. I know some groups have been working on best practices at the EU level. So we will probably have to do a work to map what is out there, what could fit in the code, and to who we are addressing the material. As I said, level 2, it was clear in the 4th edition, it was a website for the general public, but now we will have to think through what is the best approach for different target groups. We already have the experience of primary healthcare with the Latin American code. We are really targeting GPs, nurses, pharmacists, nutritionists. So as Mary said, those who are at the front line and are in direct contact with the public, because they are the ones who can pass the messages on primary prevention to the patient, but also their families in their clinical practice, and also refer to secondary prevention to those who need it. So this is definitely a very important target group, but there are others like educators, etc. So we will have to see what is the best way to put together these packages, training or train the trainers, or etc. Many different tools, and for that we will need the insight and experience of disseminators also to have this into account.
Great, thank you very much, Carolina. So unfortunately, we've run out of time now. I think we could go on for a lot longer to discuss many of these issues. I think one issue of key interest is about understanding the magnitude of risk, or kind of sort of the ranking of the messages and what people determine as a greater risk than other things, and thinking also about the elements that are not currently included in the code, or things which are, let's say, common myths about cancer in terms of the cancer-causing properties and so on. But very thankfully, we have, thanks to IARC and Cancer Prevention Europe, the self-paced learning modules online for you to follow to learn more about the science of the current edition of the European Code Against Cancer, the 12 messages, and then also an additional module on other factors not included and why. And can we really encourage everyone to follow those courses, but also to share them with colleagues too, because they will address a lot of the issues that we would like to get into and will continue to discuss into the future. But of course, today we were discussing more about the pragmatic options available for actually measuring in practice the ambitious targets of the awareness of the code's messages. And we had today some great examples from our colleagues present, from the national example experience, and then also from the ideas at the more international level, considering as well the possibility for a more expanded European Code Against Cancer replicated in other global regions. It just shows you the success of this valuable tool, that it's got the potential to be replicated elsewhere. And we really do need to have seize the momentum and have the mindset of taking the full opportunity that Europe's Beating Cancer Plan presents us with, to use all the resources to be able to evaluate to the best of our ability that we can the impact of the code itself. We're talking here specifically about awareness of the messages, but as Sylvia from Sante rightly said, we should also look into the practical uptake and application of the messages too. And the concluding remark I'd like to make to everyone is keep an eye on the opportunities that are available through the new EU for Health program, also through working collaboratively with ourselves at ECL, with Cancer Prevention Europe and IARC, of which the INCa, we're represented by Jerome as a member. There are many opportunities there through collaboration and through these specific calls for proposals, which are opened on a routine basis to really take practical action to implement the messages of the code itself. But I think now we've had a great discussion today, and we've got really some ideas and enthusiasm for taking forward different measures we can use to measure the awareness of the European Code Against Cancer itself. So I thank everyone for their support and participation today, especially to all of the speakers present for your excellent presentations given. Apologies for going a little over time, but I think it was worth it to hear from everyone there. And in conclusion, the slides, as I mentioned at the outset, will be shared with everyone. And of course, the recording was done during the session today and will be made available for repeat viewing and for those who couldn't be present today to view later. So all of these will be sent out to all the people who registered on the list today, so you will get it. And like I said, please do visit the learning portal through Cancer Prevention Europe to learn more about the code against cancer and the other factors that are not yet included within the code itself. So thanks everyone for being available today. Have a great weekend. And please, if you have any questions in the follow-up to this, don't hesitate to get in touch. Bye.
Thank you.
Thanks, David, for sharing.